So we are discussing about the pre-anesthetic checkup, in which we will take the history of the patient and mainly about the comorbidities and any medical or surgical history. We will do investigations, but we will try to do the minimum investigation. Then airway assessment, and ASA grading. ASA meaning American Society of Anesthesiologists grading, that is for physical status, and it is not a risk score. So what are we including in the pre-anesthetic examination? First, history of comorbidities, any medication or surgical history in the past, present comorbidities, present history of presenting illness, and investigations, but it will be minimum. Then for anesthesia, airway examination and ASA grading for checking the physical status of a person. Now, existing drug therapy management. So let's see. Let's divide this drug history into mainly two types. First one is metabolic or hormonal. That is going to disturb our metabolism, metabolic pathways. The drugs are oral hypoglycemic drugs. Oral hypoglycemic is discontinued before 48 hours of surgery, and insulin we can continue till surgery, but the morning dose will be omitted. Statins will be continued, steroids will be continued, thyroid drugs will be continued. This patient has to be in the euthyroid state. Oxypils will be continued, and levodopa will also be continued. Now the drugs like antihypertensive will be continued also. Diuretics 48 hours before, but if diuretics are given as an antihypertensive like thiazides, then we can continue. Oral anticoagulant will be stopped. Warfarin 4 to 5 days before, and INI should be less than 1.5 before the surgery. Low molecular weight heparin 12 to 14 hours heparin 6 hours, 12, 6 and 4 to 5 days. Now antiplatelets. So all these drugs are mainly affecting the blood and its component and its volume. In antiplatelet, aspirin 3 to 5 days, ticagrelor 5 days. This is reversible one, so just 5 days will be enough. And all the irreversible one like clopidogrel, ticlopidine will take more days. So for clopidogrel 7 and ticlopidine 14 days. Sildenafil also discontinue before 24 hours and NSAIDs before 2 days. Clopidogrel, ticlopidine and ticagrelor 5 days before and NSAIDs 2 days. Aspirin and warfarin are kind of same. Warfarin is 4 to 5 days and aspirin is 3 to 5 days. As you can see here, mainly the metabolic drugs should be continued because patients should be in the ideal normal homeostatic metabolic state. So all the statins, steroids or thyroid, whichever drug is helping in maintaining that ideal homeostatic state can continue, but oral hypoglycemic drug should discontinue before 48 hours of surgery. And in here the antihypertensive one are exceptions. We are continuing on all the other drugs like diuretics and antiplatelet, anticoagulant are discontinuing before the surgery. Aspirin low dose you can continue in any surgery except closed space surgery like brain, spinal cord or in the eyes. Now some antipsychotic drug, lithium is 2 days before the surgery, and MAO inhibitor, new MAO inhibitor you can continue till 1 day before the surgery, but older guideline was 2 weeks, so we have to remember this too. 1 day and 2 weeks. And any topical drug we have to discontinue. Smoking we have to discontinue before 6 to 8 weeks for the proper development of the epithelium lining. And herbal medicine is also advisable to discontinue before the 2 weeks. This was about the pre-existing drug history. Now, ideal nil parolar oral pediar. For adults and for children. Adults, if we are giving solid food 6 hours, and if it is just clear fluid then 2 hours, and in child same, but just the breastfeeding would be 4 hours. Here it will be clear fluids. Any formula feed or any non-human milk. Will be considering solid food only. This is for infant actually. Pre-medications that we give before the surgery. So first we have to reassure the person, that is very important. Then anxiolytic, we have to sedate, and for amnesia. This all three things will be done by lorazepam. Analgesia, morphine or pethidine, that is also known as meperidine. Then hemodynamic stability. For hemodynamic stability, we are preferring beta blockers. Decrease aspiration risk. Decrease the secretions. Glycopyrrole is preferred over the atropine due to lesser side effects. For decreasing nausea and vomiting, metoclopramide or ondansetron. Decrease infection, we will give broad spectrum antibiotic. So these are the medications that we give prior to surgery. So first we have to ensure the mental stability, and then we have to ensure the physical stability, and then prevent some complications of the surgery. So to ensure the mental stability, first we are going to reassure the patient, then anxiolytic drug, we are going to sedate, and for amnesia, the lorazepam is going to done all of this thing. So it will sedate the patient, calm down the patient, and memory will be also not there. For analgesia, morphine or pethidine. For hemodynamic stability, beta blockers are given, and for decreased risk of aspiration, proton pump inhibitor or hydrogen pump inhibitor. Decrease secretion, glycopyrrole is preferred over the aspirin, and for nausea, decreasing this complication is very important, metoclopramide or ondansetron, and decrease the risk of infection, broad spectrum antibiotics.